Hi, everybody. My name is Sabeeda Kadavath. I'm an interventional structural cardiology fellow here in the United States. The topic that was assigned to me is choosing the right hemodynamic device in a patient presenting with septic shock. So as cardiologists, we are accustomed to taking care of patients with cardiogenic shock. So the way I looked at the topic was, it is more patients presenting to me, it's more a diagnosis of exclusion. And how would I define sepsis and septic shock? So clearly, a patient presenting with sepsis has a source of infection. Now, our job is to identify where that source of infection is. And the way it manifests clinically is they have something that fits into the SOFA criteria, sepsis-related organ failure. And this is assessed based on effect on either the lungs in the form of PO2 by FiO2 ratio, neurologic status by the Glasgow Coma Scale, manifest in the form of hemodynamics, where they are hypotensive, they require pressors, end organ function when it comes to the liver, coagulopathic factors increase, platelets, you could see thrombocytopenia, and kidney function gets affected with increased creatinine or oliguria. There used to be something called the quick SOFA assessment in the past, but the services guidelines about morally has said that this is not a very good marker to assess for sepsis/septic shock in a patient. But three things: if you do not have labs, and if you do not have a lot of information on the patient, based on their respiratory status, based on their cognition, if they're altered, and based on their blood pressure, you can quickly assess a patient who's transitioning from sepsis to septic shock. So parameters that you would look for in a patient when you're doing the SOFA assessment, like I said, this grading system 0 to 4, you look at their respiration, you look at their coagulation, you look at their liver function. Cardiovascularly, map that they recommend is having a map around 70. And if they're on pressors, they have a higher score, the Glasgow score, and the kidney function. So, so in short, patient has infection, patient has those parameters that put them at a higher risk on the SOFA scale, and on vasopressors to maintain their map with evidence of end organ hypoperfusion manifesting with elevated serum lactates. So the cutoff that they use is more than or equal to 2 or 18 milligram per deciliter. And very importantly, you've ruled out hypovolemia as being the cause of the presentation. So now talking about the pathophysiology, what's happening in this patient who's presenting with septic shock? There's tissue hypoperfusion. There is release of tissue factors. There is activation of the tissue factor inhibitors, antithrombins, protein C, fibrinolysis is going on. There is thrombosis and subsequently tissue hypoperfusion. Hence, you get vasodilation. The blood pressure is going down, and there is less red cell deformability. There is cell shrinkage, there's cell death, there is a capillary leak. Hence, you see the interstitial edema, and which manifests as more work of breathing, secondary to reduced tissue oxygenation from mitochondrial dysfunction. So if you look at this curve right here, when a patient is presenting to you, these patients with septic shock, primarily, they have these 4 stages that they go through. Initially, there is hypovolemia. Then they go into this compensated vasodilatory stage where which eventually progresses into myocardial depression and then impaired oxygen utilization. So parameters that you look out for, you look at the mean arterial pressure, which you would get by non-invasive cuff monitoring. Central venous pressure, like Dr. Mebaza said, the role for pulmonary artery catheter, it is justified wherein you can get some measurements of central venous pressures and right atrial pressures. Initially, those numbers will be low when the patient has a sort of compensated vasodilatory stage, but eventually the central pressures start increasing as their myocardial function starts getting depressed and there is impaired tissue oxygen utilization. Lactate starts trending up. Systemic vascular resistance is a good marker in these patients because they're usually on the lower side. And they are requiring medications to help them support their pressures. So, like I said, septic shock, there is sepsis, there is a source of infection. So the first thing that is done is rule out the source. Pneumonia, urinary tract infection, catheter-related, pancreatitis, peritonitis, soft tissue, septic arthritis, endocarditis, empyema, sinusitis, cholangitis. Any source, you identify the infection, you try removing the source of the infection. The first hour is very critical when you take care of these patients. So you first things that you do, going from left to right, you measure lactates, you obtain blood cultures to identify the infection. You start treatment with broad spectrum antibiotics. Fluids are very important in these patients, unlike some other patients presenting with shock due to other reasons, like for example, PE that was just mentioned. Here, your goal is 30 ml per kilogram crystalloid for hypotension, or if the lactates are elevated. And then you talk about vasopressors to maintain a MAP more than or equal to 65. So adults with sepsis, crystalloid is first line, and norepinephrine has unequivocally been said to be the vasopressor of choice in these patients to maintain their hemodynamics. So it is important for us to remember and revise how these different vasopressors work, and when do you add an ionotrope like dobutamine eventually to maintain hemodynamics. So norepinephrine, which is the pressor of choice, usually works through the alpha-1. That's the main site that it works on and causes vasoconstriction. It also has beta-1 effects, which affects ionotropy, and it is the pressor of choice, like I said, in septic shock. There is not so much of a role for epinephrine in adults, but in pediatric patients, they do say that epinephrine has a role. Low dose, less than 0.1 works, has beta-1, beta-2 effects, and at higher doses, it affects the alpha-1 pathway. Dobutamine has both beta-1 and beta-2 effects, and eventually, if you are requiring an ionotropic support, if there is evidence of RV failure and stuff, then it is something that you can think of using. So norepinephrine primarily, as you can see, arterial constriction is the main thing that happens. Then it also affects contractility and heart rate. And dobutamine has more an effect on the contractility. So this is again from the Surviving Sepsis campaign. This came out last year. Norepinephrine as a first-line pressor. They do say consider invasive monitoring of arterial blood pressure. So you can put in an arterial line to measure that. They do say consider initiating vasopressors peripherally. You can consider adding vasopressin if patient is already on low to moderate norepinephrine and is not responding appropriately. And then you can add dobutamine or switch to epinephrine if there is cardiac dysfunction with persistent hypoperfusion despite adequate volume status and blood pressure. So our first equipment of choice when we do talk about identifying what kind of shock the patient is in, especially in those with a mixed component. So you talk about using a pulmonary artery catheter. There has been reluctance with, especially after the paper study 1996 that threw a bad light on use of pulmonary artery catheters and showing that it did not have any mortality benefit. But when you have a patient, when you're trying to differentiate the cause of shock, pulmonary artery catheter does have a role. And other things, it can help you guide your management therapy in patients with unstable cardiac status, complicated MI, and as a guide to your pharmacologic therapy. So what variables do you get with this pulmonary artery catheter? You get static variables and you get dynamic ones. When I say static, you're talking about central venous pressures, wedge pressure, cardiac output, SVR, PVR. You get you can measure their functions, you can get RV function, and you can get a mixed venous oxygen saturation. When I say dynamic, you measure how your therapy is acting on this patient. How are they responding to fluids? So again, Dr. said, you can like getting an echo at 0.0. You want to monitor over time how this patient is progressing, their trajectory. So you can monitor their responsiveness to fluid. You can see how the ionotropes are changing their hemodynamics. You can do like a norepinephrine challenge and see the changes in their pressures. So there it has a role to play. There are some parameters that have been shown specifically in patients with septic shock, and we can talk about them briefly. But mainly the numbers that we calculate are just a refresher. So systemic vascular resistance, PVR index, cardiac index, stroke volume index, stroke work index, and oxygen delivery. More importantly, you get your cardiac outputs, and you can also measure the mixed venous oxygen saturation. So we spoke about Swan-Ganz catheters, but when do you not use this? It's absolutely contraindicated, and you have to measure the risk benefit in patients with left bundle branch block, if they have some tricuspid or pulmonic heart valve replacements, or if they have pacing leads. So here in this table that you see here, we're talking about the hemodynamic profiles of patients with pulmonary artery catheters. So septic shock would be classified under distributive shock. And in these patients, in their preload, so early on, it is equivocal. There isn't much a change in their preload status, but later on, the preload starts getting low. And their pump function, it could be high or low occasionally. So more often than not, the cardiac output is higher than normal. So again, that's not a very good marker, but SVR is almost always low in patients with septic shock. And their mixed venous oxygen saturation will be more than 65%. So there are, for example, this slide that I have is from the Edwards Life Sciences. They have developed this continuous cardiac output catheter. It's a thermodilution cardiac output catheter that can continuously monitor for you. Using the distal port, you can get the PA pressures. The VIP port, you can get RA. It's located near the RA SVC, and you can get proper waveforms of the RA there. You can also, of course, calculate the output constantly, and you can manage and guide your therapy. And you also have the continuous oximetric monitoring that can happen using fiber optic reflectance spectrophotometry. That also is another method to continuously estimate the cardiac output. So there is another thing that they have, which is called the Hemosphere Advanced Monitoring System. So there are different ways. You can do it non-invasively, you can do minimally invasively and invasively. So non-invasively it can be done by using an oximetry sensor. You get oxygen saturations in time. You can use the flow track sensor. If you have an arterial line, if you connect the flow track sensor, you can get measurements from there. And invasively, using the Swan-Ganz catheter and the oximetry central venous catheters, you can get invasive measurements and pressures. So how this guides your therapy is you can get end-diastolic volumes, you can get ejection fractions, you can get stroke volumes. And the goal at the end of the day is that you want to maintain perfusion. So knowing the volume status, you can guide your pressure such that if you want to increase contractility, you can help add medications that would help with that. So there are some inadequacies though when you're using a central venous catheter and a pulmonary artery catheter. So it has been shown that both the CVP and the pulmonary artery pressures, they have poor predictive value sometimes in assessing fluid responsiveness, especially like if you are giving like a 500 cc bolus and you're looking for an increase in cardiac output, sometimes it may not be as accurate, and it may also be affected by other concomitant factors, like if patient has regurgitation, RV dysfunction, pulmonary hypertension, or variability in the intrathoracic pressures, then these measurements may not be as accurate. So that's something you need to keep in mind. Cardiac output, we do traditionally using the FIC cardiac output. You can also do thermodilution by using the lithium dilution devices, and wherein you measure the washout curve over time, or by using cold saline, you're injecting into the central vein, and then you're analyzing variations in blood temperature with a temperature sensor that's there on the arterial chamber. So these are ways that you do monitor. Something new that is used in septic shock is the pulse contour analysis. So they measure the pulse pressure variation which is a marker on the position on the Frank-Starling curve. And you can see by changing preload how this pulse pressure variation varies, and it is a surrogate marker for the fluid status of the patient. So if you decrease preload, you have more PPV, and you from 0.4 to 0.2 here, you see that there is more contractility. So these are some ways you can assess the patient's hemodynamic status. You can also, the same principle applies to stroke volume variation. And if there is a stroke volume variation, which is the difference between the maximal and the minimal stroke volume divided by the mean multiplied by 100, if there is a more than 10% change in that after you give fluids, it means that the patient has responded optimally to the fluid challenge. There are some provocative maneuvers that can also be done. What I show is a passive leg raising maneuver. You start with the head elevated to 45 degree, reposition the patient, legs are elevated 30 to 45. There is transfusion of blood going from the legs to the thorax. And that, with that, there is an increase in the cardiac output. It means that the patient is fluid responsive. So these are some minimally invasive ways of assessing fluid responsiveness. So when you have these patients who are coming in with distributive shock from septic shock, there is a role for other non-invasive measures like echocardiography and point-of-care ultrasound. What you would expect to see in a patient with septic shock, they will have small cardiac chambers and they would have high contractility. And the wedge, like I said, would be normal or reduced. Cardiac output is usually normal or increased. SBR is low, and the mixed venous oxygen sat is more than 65. When you do a point of care ultrasound, you're looking at the pericardium. You're looking at the intracardiac chambers, their relation to each other, LV function. You're looking at the RV function. You're looking for IVC collapsibility, diameter. You're looking at the lungs, pleural space, peritoneal cavity to see if there's any infection that you notice there. Aorta, you look for aortic dimensions. And of course, you can use LVOT to calculate your cardiac output. You're looking at the femoral veins, portal veins, hepatic veins, renal veins to look at the volume status. There is something called thoracic electrical bioimpedance, wherein you can put electrodes on the chest wall. You measure impedance across the thoracic cage. If there is more fluid in the chest cavity, there is less impedance because fluid will conduct your electricity. And you can extrapolate sort of to see how to determine what the patient's cardiac output is. Another similar thing is a thoracic bioreactance. It's modification of the impedance. Here you look at the signal to noise ratio. So there's a phase shift as the current voltage travels across the thorax. And what is proposed at that the phase shift, it depends on the pulsatile flow. And it doesn't so much depend on the intravascular and extravascular fluid in the thorax. So it is a little more accurate determination of the cardiac output. You can check for perfusion. There is oximetry, of course, that we all use in the ICU to check. There is a variable called the Pleth variability index, and that has also been shown to modestly predict fluid responsiveness in the OR. You can non-invasively, there is the near-infrared spectroscopy. It's a downstream tool that you can use to assess microcirculation, oxygen delivery, and consumption. You can also check for capillary refill and lactate. These are two parameters. There has been a multi-center study that shows that maybe capillary refill is a better marker compared to lactate at 72 hours. And there is a signal towards mortality benefit when it is used in patients to assess their clinical trajectory. You can also measure microcirculatory blood flow, and the sublingual mucosa is preferred, especially because it shares embryology with the splanchnic circulation, and it's easily at bedside, you can assess the sublingual mucosa. So you can image by using dark field imaging, you can use near-infrared spectroscopy and measure the microcirculatory blood flow. We have a spectrum of devices when it comes to cardiogenic shock. You have the balloon pumps, impellers, tandem hearts, ECMO, which will be discussed later today. But when it comes to septic shock, it's more about fluid status. It's more about resuscitation. It's more about your medications, vasopressors. So it would be wonderful to have mechanical devices to assist you, but that doesn't seem to be where we are at right now. So I'd like to end with saying, when it comes to septic shock, remember it's about time. Make sure you identify the source of infection, make sure you prevent the end organ dysfunction and act in a timely fashion. Thank you for this opportunity to talk.